Nuclear medicine confuses 99% of medical students, which is exactly why mastering it can put you in the top 1%. I remember freezing on my first nuclear medicine question, staring at images that looked honestly like meaningless blobs. But what I discovered changed everything. In this lesson from our coaching program, you'll watch real medical students work through these concepts. You'll see their breakthrough moments and the exact insights that help them score 260 plus and match into competitive specialties. You'll see the difference between memorizing patterns and understanding principles, the key to transforming your exam performance.
What I'm going to do is I'm going to read it at about the same speed that I would read it in real life to give you a sense of how slowly I read questions so that I understand everything that I'm reading and I don't have to go back and reread things. So a 55-year-old man with type 2 diabetes mellitus, normocytic anemia, and chronic kidney disease comes to see his primary care physician for evaluation of exertional dyspnea. Blood pressure is 141 over 93 millimeters of mercury, and pulse is 82 per minute. BMI is 35. Single photon emission CT images at rest and after 5 minutes of exercise on a treadmill using separate intravenous injections of technetium-99 labeled perfusion agent are shown to the side. What is the pathophysiologic chronology? What is the significance of the images of the stress and rest? So I'm going to put this in the Google Doc and I'm going to have you write your pathophysiologic chronologies. Again, I read it that slowly because that's when I was taking my exams, that's about as slow as I read it. And I usually finished with plenty of time. And the reason I could finish in plenty of time is because I was reading it so slowly that I could actually think about it as I was reading it, as opposed to what most of us do, which is we read it really quickly and then we like feel so pressed for time that we read the next sentence. I would read it actually that slowly. And so because I read it that slowly, I could actually think through. Because the problem with timing this is always that you read it twice. I want to go through next what the pathophysiologic chronology is, or at least the summary one, to show you what I would do in a time setting or what I would be thinking in this situation. So the summary is that he had developed coronary artery disease, right? Because he had diabetes, he was obese, he had a number of risk factors that led to stable angina. So that's why he had pain or ischemia under physiologic stress, where the demand increases beyond where the supply can supply the blood. And that leads to reversible ischemia on the nuclear medicine scan. So it's this last part that I really want to focus on, because this is something that I didn't understand, I don't think at all when I was a medical student. Like I just didn't understand the principles of it. Very frankly, as I was making this presentation, I realized that there's a lot of things I also just didn't understand, period, about nuclear medicine scan. So it's fun. So we're going to talk about nuclear medicine. So I hope you're excited. So let's start with Alex. So Alex, can you tell me what is the basis for nuclear medicine scans? Probably the hardest question because there's no context. So what is the basis of a nuclear medicine scan?
Yes, I'm not exactly sure, but I'm guessing it's just a radioactive kind of label, and it measures the blood flow to a certain part of the body through labeling like certain blood cells.
That's pretty close. Yeah. It's slightly more general than what you said, right? You are correct. That is a specific kind of nuclear medicine scan, like the cardiac scan, like the SPECT scan that we just saw. That would be true. That's like looking at blood flow to the heart. But nuclear medicine more generally means that there's some sort of substance, right, that is an unstable nucleus, hence the nuclear medicine name. They inject it into the body. Usually it's a vein. I guess not always. And then that substance distributes to the body. And as it decays, it will emit some sort of radiation. That radiation is detected, and then they can localize where that radiation came from, either in a 2-dimensional way or a 3-dimensional way. So that sounds complicated, but really I'm going to show you, it's actually not that bad. So Andy, yeah, pretty complicated, right? Basically, I inject something into your body and it decays. And when it decays, it releases light. And that light is detected outside the body. That's it. That's pretty much it. So there's a ton of scans that work this way, and we're going to talk about them. Andy, can you tell me, how is a nuclear medicine scan different from x-rays or from CT scans? What's the difference? What's the big difference?
I was hoping you would not call on me.
We're all friends. Plus, like, you guys can rest assured that I didn't know the answers to a lot of these things, so I hadn't really thought about them before I had to make this presentation.
So X-rays, I know you use X-ray, just a type of like energy to shoot through. And then if it doesn't go through, then obviously it turns out as white. If it does, then it turns out as black. A CT, I know it's like more radiation. That's all really I know about CT. And it gives like more picture towards like just more details, but it's not as detailed as like MRI. And for like nuclear medicine, like SPECT, according to Google, it says a single photon emission.
It's useful, yeah. Single photon emission computed tomography. Yeah. I honestly didn't know what that stood for before checking Google either. So let's talk about it. So you're right. The X-rays, so nuclear medicine, like we said, I inject some sort of radioactive material in your body, it decays and it emits light. And then we are trying to look at some tissues of interest somehow, right? Oh, Boogie wants to give it a shot. Please, Boogie, I would love it if you would explain.
What I understand, the two different things when we're shooting patients with X-rays or with radiation, we're usually trying to blast the patient with radiation, and then whatever it is, the negative, right, film that we don't get, that's how we're trying to that's how we're trying to distinguish what's happening within the tissue. Whereas with the nuclear study, we're actually letting the patient, we're trying to radiolabel like specific tissues. The tissue itself blasts away radiation from it. So therefore now we can see what is happening, right, from the emitting source, which is specifically the cells themselves that got labeled. That was my basic understanding. So particularly, say for example, if we radiolabeled something, say iodine, and we wanted to see where it was going to go, if we could see if something was hot specifically, I guess we use the term hot in terms of like radiation and military things like that. If the image is hot, that means that that particular source is actually where the radiation is coming from. So therefore, that may be the area that's actually getting perfused. And if the area is cold, then that is the area that's most likely not being perfused. And that's why I think nuclear studies are more of a physiological type of study versus something that is just that you could see in a non-dynamic, I should say, from a static picture.
Normally, I make fun of people for giving med student answers of saying fancy words, but not actually meaning anything. But you actually said fancy words and they meant basically exactly what it is. So I'm very impressed. How did you know that?
My father was a nuclear medicine tech over at Cedars-Sinai. And I used to go follow him around over at Cedars-Sinai when I was a kid, when he used to let people bring their kids into the hospital, like back in the day.
That makes me feel a lot better about myself because I was a chemistry major and I didn't know most of this stuff. And I'm pretty certain I wouldn't have been able to give nearly that explanation before. So thank you. I appreciate your honesty. It preserves my pride a little bit. Really thought about it that way. But yeah, nuclear medicine, basically you're injecting something and it's going to the inside of the body and then it's shining a light from the inside out. An X-ray or a CT, you're basically shooting radiation at the body and then you're looking at, the negative image that's formed when it either shoots through or doesn't shoot through tissues to varying degrees. So the nuclear medicine scan, absolutely right, is a much more physiologic exam versus like X-rays and CTs is typically much more static unless you're using a lot of like contrast. If you're doing like CT angiogram and you're looking at the vessels themselves, that's really good. So to describe what Boogie was just saying in terms of words, so X-rays and CTs, basically we have an X-ray source on the outside of the body. So if this is our body right here, this is my body. And then I've got this X-ray source here, I'm gonna shoot rays through the body. And then there's gonna be some detector here where if it passes through, again, it's going to be black. And if it doesn't pass through, it's going to be lighter or white. The radiation source is on the outside of the body and we're shooting it through the cells. And then we're seeing on the other side what sort of image is how much of the X-rays actually make it through. That's true of X-rays and CTs. The difference is X-rays is 2D, CT is 3D, right? But it's the exact same principle. Radiation on the outside shooting. So X-ray detection, is dark. So versus like a nuclear medicine scan, right? So Boogie mentioned, right, the thyroid scan, right? So you've got some sort of radioactive source that you're injecting into usually a vein, right? So it's some sort of decaying nucleus, like decaying material. So then it goes, in this case, right, it's iodine, right? So iodine goes to your thyroid, right? Because your thyroid is the only part of your body that uses iodine physiologically because you need the iodine to make your thyroid hormone. So it goes to the thyroid and then it's sitting there in the thyroid. And some fraction of it is going to decay at various times. Some of it's going to decay on the way there, but most of it's going to decay because most of it's going to just be sitting there in the thyroid. So it's just going to decay while it's there. So it's going to decay and it's going to let off radiation. And so that radiation is going to go in all these different directions. And then we're going to have some way of detecting it. And so we're going to see, right? This is scintigraphy, right? So it's 2 dimensions. But that's the general idea. We inject it into the person. It goes to our organ of interest, and then it emits some sort of radiation, and we detect the radiation from the outside. As opposed to an X-ray, whereas we'd have the X-ray source here, it is shining through their body, and then we're detecting it on the other side. So again, to demonstrate this, right? So the X-ray source is on the outside. The nucleus is really, sometimes I guess it's within the cell, sometimes it's not. But the general idea is that it's in the body, it's in the organ of interest. And so that radiation is then detected on the outside. And so if it's scintigraphy, right? So on thyroid scans, it's 2-dimensional. If it's SPECT, it's 3-dimensional, but the idea is the same. So this is the core principle. So again, take me as your example, not Boogie. I didn't understand this really. I vaguely understood it, basically, not even to the level that I think Andy and Alex described it. So I want to ask what questions you have before we move on, because this is like the core principle that we're going to be hammering again and again. So I want to make sure that we understand that I did an okay job of explaining it. You're just like so confused that you don't know what to ask, or you're like, oh yeah, all right, I get it. Let's move on. All right, we'll see, because I'm going to ask you guys a lot. Boogie said I did a great job. Thank you, Boogie. That actually means a lot. Let's talk about some other organ-specific nuclear medicine tests. So the physiologic tests, as Boogie was describing. So Shama. So in nuclear medicine, you're going to give these radioactive elements intravenously, usually. So they're going to distribute throughout the entire body. But we're often trying to visualize specific organs. So what do you do to the radioactive elements to ensure that they go to the organs that we want? This was a question that I didn't know the answer to. I had to look it up.
I actually am not sure at all. I was going to say we put lead to protect our thymus, but that's not what the question's asking.
You're supposed to cover up, right, with your lead. So I guess in fairness, there's not really like a one like universal answer. So iodine, we're taking advantage of the fact that iodine itself, right, goes to the thyroid. So it's pretty clever, actually. Like iodine, your thyroid is the place that needs iodide. So you just put radioactive iodide in the body and it magically goes to the thyroid, like all iodide does when you put it in the body. And so the idea is that like in like PET scans, they do it to glucose, right? They put it to, because glucose, the idea is that cancer takes up glucose more. But in other organs, what they do is there's some sort of compound that they complex it with, and that for whatever reason, it can accumulate in a particular organ. And this is what I didn't know. So Boogie, I'm going to ask you, because I'm pretty sure that I didn't know this. Do you happen to know in myocardial nucleostasis, what do we do to ensure that the radioactive elements go to the heart?
I believe we tagged it with a compound called myocardial light. At least that's what I remembered from some of the patients that respond to that.
I think that's the
coding
complex, and I think that's the brand name.
Oh yeah, that's all I remember is what they tagged it with.
So there's sodium is the element, right? So you just like radioactive iodine, right? Technetium is the actual element that is decaying, but it forms a complex. So basically it's called sestimib is one of them, and then tetraphosmin is another. But basically, it's just chemicals that you use, and for whatever reason, sestimib and tetraphosmin go to the heart. So to show you I will show you a picture again. So basically, sestimib, so the sex in like sextet, so 6. So there's sestimib means there's 6 mibs, so sestimib. So you can really impress. I'm pretty sure no one very few people other than maybe like the radiologists or the nuclear medicine techs knew actually what these words meant. But so if you ever say, oh, it's sestimib, like they'll be very impressed. So sestimib just means that there's 6 mibs, right? So there's whatever the technetium is complex, right? So there's 6 mibs, there's sestimibs around it. So same idea, we inject it. And this time, instead of it going to your thyroid, for whatever reason, the sestimibs, just like the tetraphosmin, goes to the heart. And then once it's in the heart, it's going to accumulate and it's give off radiation. And then that radiation we're going to detect on the outside, and it's going to look like this. The difference is that in this case, we take a 3-dimensional scan. CT is a 3-dimensional scan. We're taking it from all angles, so we can create a 3D image as opposed to an X-ray or a scintigraphy like the thyroid scan, where it's going to be 2-dimensional. So maybe you've heard sestimib before. Now you can actually know what that means. Questions so far? Does this make any sense? All right. Work with me. This is actually it actually comes up a lot in clinical practice. And in general, I think it's important because these sorts of things, they're not that hard to understand when you take a little bit of time to understand it. So Shama says mind blown. I hope in the good way. So Danielle, again, another impossible question that I wouldn't have known. So do you happen to know what tomography means?
I'm thinking I don't know what it means. I'm thinking of topography, or the one where it's like talking about the landscaping of the earth. I know it's not that.
So the definition is it's imaging by sections or sectioning, right? So you know how like when you take a CT scan and you're like scrolling through and it's basically like you're slicing in 1 millimeter slices or 2 or 3 millimeter slices the body and you're looking at different slices? That's essentially what tomography means. You take some sort of penetrating wave, like an X-ray, right? Or a nuclear medicine, something, a gamma radiation, and you just section the body. So I think the easiest way to think about it is just like a CT, right? Because the T of a CT is tomography. So computed tomography is what CT is. So SPECT, the CT is the same CT. Single photon emission computed tomography. So that's just what it means, just sectioning. So this, right? So SPECT, S-P-E-C-T, again, same thing. We're just imaging in slices. So this is the heart at different, we're just slicing the heart in different orientations and at different depths. That's it. That's what tomography is, using some sort of penetrating wave and imaging in slices. So now, what are, Deb, again, it's an impossible question. So what are the 3 major kinds of nuclear medicine scans? Do you happen to know? I didn't.
Is it contains in white, PET, SPECT, and Scintigraphy?
Oh my gosh. You may have said all 3 of them, but you definitely said 2 of them, which makes me feel insecure, but very good. Yeah, PET is one. So positron emission tomography is one. Right? Again, tomography, useful to know what tomography means. Again, makes sense. Imaging in slices by using a penetrating wave. Scintigraphy, which I don't know if you said, you might have, I just didn't hear it. Scintigraphy, so that's like the 2D image that we take, like the thyroid imaging. And SPECT, right? The one that we just saw, the single photon emission computed tomography. Again, you'll notice the tomography word, like, it comes up a lot. Now we know what it means. Cool. All right. So, Hadra, what is the basis for PET, scintigraphy, and SPECT?
I think the basis is the same as, like we said, the nuclear medicine. And that is that something like in PET, there is positron, and in SPECT, they're emitting light, and then we can look at an organ by sectioning it. That's what it is.
Yeah, essentially. Yeah. So in PET, right, the key is that the radiation is positrons, right? In scintigraphy and SPECT, we're using gamma radiation. So in this case, it's an actual particle. In this case, I mean, technically everything's a wave particle duality, blah, blah, blah. But yeah, so we're using positrons in one case and we're using gamma radiation in the other. But for SPECT versus scintigraphy, Paul, what exactly is the difference and what would this be analogous to?
I'm not sure. I'm trying to figure it out.
Yeah, I did. Honestly, these are just so that I can get a chance to explain this to you guys. I would never have known a difference. So basically, scintigraphy is a nuclear medicine. So again, they both use gamma radiation. Scintigraphy is 2-dimensional. SPECT is basically it's just a 3-dimensional. So again, the key thing to remember is this: the CT and SPECT stands for the same CT that with like the X-ray CT. Cool. Does that make sense?
Yeah.
Perfect. All right. So yeah. So scintigraphy is to X-rays as SPECT is to CT. Literally, SPECT has CT in the name. Cool. All right. Questions before we move on. Again, this is a pretty heavy topic, but again, I think it's important to understand because it shows up not infrequently. Thyroid scans are all over step 1 and step 2. Like stress tests, like the one that we saw here, is pretty common in life, but definitely in step 2 and shelf exams. And even maybe some for step 1. I think I've seen it a little bit. All right, so here's some examples, right? So again, PET, again, positrons, right? So, and it's 3D, so because it's the T is tomography, right? So positron emission tomography. And so again, the idea is that we we inject sugar that has radio-labeled glucose, right? So, sorry, we give radio-labeled sugar, right? Radio-labeled glucose injected, and then tumors often take up more glucose. They don't use their mitochondria, and so they take up a lot of glucose, so they rely on anaerobic glycolysis, and so they are really bright, so to speak, right? Or dark in this case, because there's just a lot of it there. So the radiation just goes a lot to those areas. Scintigraphy, again, is 2 dimensions. It uses gamma radiation. So thyroid is the classic example of that. In SPECT, the most common one that you'll see, again, the CT is computed tomography, meaning imaging in slices by using a penetrating wave. And so the SPECT would be like a classic one for that. All right, so let's talk about some examples. Pooja, a VQ scan is another example of nuclear medicine. How would you guess that the different ventilation and perfusion images are obtained? What would you think? How would you do it? If I wanted to look at ventilation and I wanted to look at perfusion, how would you do it?
I honestly have no idea.
I didn't know this either. So the patient is given an inhaler, right? So the ventilation scan, you got to look at how well air goes into the lungs. So you give a patient an inhaler. In that inhaler, there is a radioactive substance. They will spray that substance and it goes into their lungs. It goes into my lungs. And then it's going to decay. As it decays, it's going to give off gamma radiation. So it gives off the gamma radiation, and then it's a scintigraphy scan, right? So it goes, it distributes to the lungs, and then you look, and this is what it looks, well, if it's normal, right? This is what it looks like. It looks like the thyroid scan, except for 2 lungs. So that's the ventilation scan. So, the perfusion scan, well, I'll explain the perfusion scan first. So the perfusion scan is basically the same thing, except for now you're giving an injection of it, just like we did for most of the other ones. Give the injection, and now it goes to the lungs again. But in this case, it's not going via the airways, it's going through your blood vessels. So it goes via your blood vessels, and then it perfuses the lungs, and the same thing. Then it just emits radiation and you pick it up on the outside. So it gives off radiation and then boom. And this is what you see, these kind of like ragged things over here. So Ruru, what kind of nuclear medicine scan is VQ? Is it scintigraphy? Is it SPECT? Or is it?
Wouldn't it be Scintigraphy?
Boom. You are right. Yeah, I wouldn't have known that. Good job. God, yeah, it's right, because it's 2-dimensional. It's not a CT, a SPECT, or a PET, because those are both 3D images. Yeah, it uses gamma radiation. No way that you would have known that it uses gamma radiation. But yeah, anything that's 2-dimensional is usually going to be scintigraphy. So Sujif, do you happen to know what's the diagnosis? If the ventilation scan looks like this and the perfusion scan looks like this, what's the diagnosis? How about this? Pregnant woman just gave birth, and then suddenly she has this acute onset shortness of breath and starts to feel ever so slightly lightheaded and has some chest pain.
Well, in her amniotic fluid embolism, any kind of embolism.
Yeah, pulmonary embolism. Yeah, in that case, it would be an amniotic fluid embolism. But yeah, exactly. And why? Can you explain to me why, based on these nuclear medicine scans, that this would be a PE?
So in the left lower basal region, it looks a little lighter compared to the other fields.
Right, because remember, right, if you go back to my handy dandy image, we just injected this stuff into the lungs, but it's traveling there via the blood. And so if it doesn't perfuse a part of the lungs, then guess what? That part of the lungs is not going to be dark. Pretty straightforward. That's the basis of most nuclear medicine scans, or a lot of nuclear medicine. Not all of them, but a lot of them. That's it. Cool. Questions, thoughts, concerns? Oh, Andy's saying the ventilation was normal. Yeah, exactly. Yeah, ventilation is normal. Yeah, sorry. No reason that you would have known that. But yeah, this is normal. You haven't seen enough of them yet. Yeah. But you see how it's roughly evenly distributed. In fairness, I guess if you told me that this was abnormal, I probably would have believed you. This looks more abnormal to me. But yeah, in fairness, I'm by no means an expert. If you had shown this to me and a radiologist had claimed up and down that this was abnormal, I would have believed it. So just being honest. All right, Yuki. So for the following, can you tell me whether this is an example? We're going to do this for all of you guys, but we'll start with Yuki. So can you tell us, are these examples of nuclear medicine or not? This is like a game show. So ultrasound, Yuki, what do you think?
Not nuclear medicine.
Not nuclear medicine. Great. What's the basis?
The basis is the fact that there is some kind of radioactive tracers not being administered.
Ultrasound? No, it's not radioactive.
So that's why it's not.
Oh, I see. But what is the basis of ultrasound?
Ultrasound uses, I guess, ultrasonic frequency waves to be able to lend in reflection of that is what is going to be the imaging that you see.
Yeah, it's just sound waves. Perfect. Alec, PET scans, nuclear medicine or not?
Yeah, it is nuclear medicine.
Boom. Great. Andy? Thyroid scan with radioactive iodine. 1, 2, 3. Andy, what do you think?
Yeah, so it uses iodine because thyroid uses iodine. I think you said that it was the only organ that uses iodine, and then
yeah, I don't know. You guys are probably going to find an example where another one does, but it's the major one. If there's not another. Yeah, so it's scintigraphy. Great. Boogie, X-rays. What do you think?
That would be negative, sir.
Yes, very good. Yeah, so if you want to see X-rays, right, so our discussion of X-rays, you can look at cardiovascular vignette number 11, because we talked about X-rays there. But yes, that is correct. How about HIDA? Oh man, Shama, what do you think?
I think HIDA is because we give a dye.
Very good. Yeah, it's scintigraphy. Right? Yeah, you give it, you inject it. I don't know what it stands for, but it goes to your gallbladder, collects in the gallbladder. So it's a way to visualize your cystic duct / gallbladder. So if you have cholecystitis and if you have a blockage of your cystic duct, then it will not fill up your gallbladder. So you will not see it highlighted. Danielle, a myocardial perfusion scan with thallium-201.
This is, right? Because it's one of the thallium is the one we spoke about.
Yeah, actually, I think we talked about technetium, but yeah, there's other elements that you can use. I think thallium is one.
Is that a similar element that just a different one you could use?
I don't know. I think so. Yeah. I mean, there's different ones. I think technically, I think technetium is the most common, but yeah, it's just another, to my knowledge, it's just another element of the keys. Deb, how about MRI? What do you think?
Like it's not nuclear.
Not. Very good. Yeah, very good. Man, I'm impressed. That's good. You guys are doing well. All right. So let us talk about PET scans. Oh, thank you. I knew someone would do this. Yuki looked up HIDA. So hepatobiliary immunodiacetic scan. Wow. Yeah, so I'm going to guess that the immunodiacetic acid is, I assume that is, it probably just accumulates in, I'm going to go on a limb and say, just like the cestum maybe. That's the thing that we give to make sure that it goes to the gallbladder, but I could be wrong. The immunodiacetic acid. Wow, quite a mouthful. So Hadra, in PET scans, the radioactive material is bound to what substance? Why would that make sense? Yeah, exactly. And why does it make sense?
Because we said that the cancer cells, they depend on anaerobic glycolysis and they take up glucose. They don't have mitochondria.
Wow, man, you guys do listen to me. Oh, that's awesome. Yeah, exactly. Yeah. So the idea, the theory behind like why cancer takes up more glucose is, I guess it's more metabolically active, but part of it is that, remember that your mitochondria is responsible for releasing the cytochrome C that allows for apoptosis. And so one of the hypotheses is that you suppress the mitochondria just like generally. And so it allows you to escape from apoptosis, but also as a side effect, you also are losing the mitochondria's ability to undergo oxidative phosphorylation, right? So remember, there's two ways to make ATP from glucose, right? There's anaerobic and there's aerobic glycolysis. So anaerobic glycolysis is very inefficient versus if you go through and you make CoA and it goes through the TCA cycle and it goes through oxidative phosphorylation and all that stuff in the electron transport chain. That's by far more efficient, but that requires the mitochondria to function. So the idea is that you're shutting down the mitochondria in part to evade apoptosis, right? The mechanisms of killing the cancer cell, but that actually you are also shutting down the cancer's ability to use glucose efficiently. And so it has to use glucose inefficiently. It's an interesting idea. I don't know, like, how proven it is, but it's a cool way to tie this in with biochemistry, as I love to do. Yeah, so the idea is that cancer needs that extra glucose because it has decreased mitochondrial activity. And so it has to undergo anaerobic glycolysis. So if you would like more, I would recommend the biochemistry lecture #1, the one on the TCA cycle, etc. Paul, what does a PET-CT mean? What does that mean? And what are we actually doing in a PET-CT?
I think it's a combination of both technologies where you're using traditional CT to map the anatomy maybe, and then you use the radioactive material to target, I think, usually cancer cells and patients with malignancies.
Yeah, exactly. Yeah, it's basically two scans and they're superimposed on each other. So the PET scan is a nuclear medicine scan. And again, like we just said, that's where you give radioactive labeled glucose. It goes to the cancer, usually goes to the cancer because the cancer needs more glucose because it's undergoing anaerobic glycolysis. And then the CT scan is just a normal CT. You have an X-ray that shoots through the body and then you have the negative on the other side. Yeah. So yeah, the PET separate and the CT is a CT separate. What's interesting, so I learned from a radiation oncologist that the way that they do it is different. So I want to say that a CT scan, they make you hold your breath because it's pretty fast. CT scans are pretty fast. So you would actually be able to hold your breath versus if it's a PET scan that they don't have you hold your breath because it's like, it takes a lot longer. So they're not going to have you hold your breath for, I don't know how long it takes, but it's probably more than several minutes. And so what's interesting is that if the organ of interest moves with respiration, then it'll be in a different position on the PET scan relative to the CT scan. It's cool. So I think he was talking about like pleura, like if you're worried about it being in like the pleura versus in like the lungs itself, you can tell. Because the pleura shouldn't really move. The pleura shouldn't really, like the position, if it's a pleural met, it shouldn't really move that much. Versus if it was like, I don't know, say in like the pericardium or say it was in like the lung, that would move. Because as you inhale, the lungs are going to expand. And so if it was in one part of the lungs, when you were exhaling on inhalation, it'll be farther inferior. Just a little fun fact for those of you that are interested in radiology or in radiation oncology. So, or even surgical oncology. So Pooja, what colors are used to designate the radioactive tracer in PET scans? Or how about in thyroid scans? And what's the significance? Kind of a vague question.
I've always seen like yellow, red, but I don't know if there's like a...
Yeah, exactly. Yeah, so thyroid scans are black and white, right? That's because they're usually, I presume it's because they're displayed by themselves. They're not overlaid something else. So you'll see this. This is a PET scan just by itself. There's no other, it's not overlying another image. This is all generated from just the PET itself. Versus a PET CT, it's usually orange or some other color that's not black and white, because CTs are displayed in black and white typically. And so it just allows you to see the contrast more. So you can see the image itself, and then you can see the PET on top of it. That's all. You can see how the heart is really bright. Your heart is using up a lot of glucose, so that makes a lot of sense. Cool. I think your bladder too lights up. Is that right? Which kind of makes sense, because if you're giving a lot of glucose, it would make sense that like you would overwhelm your kidney's ability to reabsorb it. I never thought about that, but that would make a lot of sense. Yeah, because typically you see the bladder as pretty bright. I don't know if any of you guys know, but yeah, that would make a lot of sense. Because typically, remember, glucose above 200 milligrams per deciliter, your kidneys can't reabsorb it. And so, yeah, so Boogie confirmed. Thank you. Yeah, the bladder is hot on the scan. Or just, I think scans in general, though. Is that right, Boogie? Yeah, Boogie says yes. Yeah, which makes sense. I never thought about that. Yeah, I wonder how much glucose you give. It's presumably a lot. It has to be a lot. Otherwise, it shouldn't end up in your bladder. You should be able to reabsorb it. Oh, oops. Here we go. All right, so I guess you saw the answers, but so Ruru, for the included images, what are the images above and below, and how are they obtained? What do they do physically? What does the patient have to do?
The CT scan, don't they lie down and go into that? No, I'm thinking of an MRI.
They still lay down on a thing. It just goes a lot faster. Yeah.
Top one, yeah, I know that computer derives with computer. Do they inject the contrast with the top one?
Yeah, so it's not contrast. Remember, so a PET scan, what are they actually injecting?
Radio-labeled isotope.
Yeah, radio-labeled sugar. Yeah, just giving sugar. Goes to the cancer, ideal, usually. That's the idea. And then it decays, and then, yeah, and then you measure it. So, yeah, I assume that they just have them sit in the same place. Because otherwise, I don't know how you would possibly overlay them. So I think they just do a CT scan first, and then second, or maybe the other way around. But yeah, they're just two separate scans, and then the computer just overlays them. So yeah, so the above is a PET scan overlaying a CT, and below is just a normal CT scan that was overlaid by the PET scan. So yeah, so the PET scan, yeah, like we said, injecting glucose, it's bound to a radioactive material. The cancer uses glucose more than surrounding tissues. It's brighter on the PET scan usually. Cool. All right. Again, same thing. So this is a thyroid scan. So same idea, right? Decaying nucleus to your thyroid, gives off radiation, and then this is what you... So Sujith, how do radioactive iodine uptake tests work?
You radio-label the iodine and you inject it via IV, and you'll see it being taken or being uploaded in the thyroid gland.
Yeah. What instructions do they give them before they go to the test? What are you supposed to do for probably days? I think it's days beforehand at least. What are they supposed to do or not do?
Restrict the iodinated salt.
Yeah, not just like anything with iodine in it.
Yeah.
There's tons of iodine and amiodarone, like just random things. You just have no idea. Yeah, why would that make sense?
Because on the test, on the day you want to do the scan, then I don't think you'll be taking up much iodine as to compare to the actual amount administered to the thyroid gland.
Yeah, exactly. So I'm giving radioactive iodine and it's going to the thyroid. So yeah, so the thyroid cells, ideally they're actively synthesizing thyroid hormone, right? So any of the cells that are actively synthesizing thyroid hormone will take up that iodine and they'll give up more electromagnetic radiation. However, if I give you, so it's not, a slight difference in terminology. It's not actually radioactively labeled. It actually is radioactive iodine. Like the iodine itself is actually the thing that's decaying, right? Whereas in the Scintigraphy itself, right, the 6 MIBs that you put on the technetium-99, like technetium is itself the thing that's decaying, right? Or in like the case of a PET scan, the glucose itself has something that has like a radioactive nucleus on it. So that's why we call it radioactively labeled, right? The glucose, it's a regular glucose molecule. It just has something tagged to it that is radioactive. In the case of the iodine test, it's not radioactively lethal. It actually is just radioactive. But yeah, the whole point is that if I gave you normal iodine, it's going to compete. It's a competitive inhibitor. It's going to compete for uptake into the thyroid. So I want to minimize the amount that you eat. I think they say the same thing with PET scans. You're not supposed to eat like anything, but particularly things with glucose in them before the scan. Because again, same thing, right? You want the cancer to be as hungry as possible for glucose. Boogie, so you said the same principle as when we give, yeah, exactly. Yeah. So KI, yeah, exactly. So the idea, so if you get radioactive, Boogie, do you want to talk about that?
When we have patients that have exposure to radiation, like a nuclear accident or a fallout, or such as in the case of 2011, when we had the Fukushima meltdown over in Japan after the tsunami, we had a lot of folks in the military were already being exposed to the high levels of radiation because of what had happened with the meltdown of the nuclear reactor. Because all that radiation is already, that ionizing radiation is in the form of iodine that can be taken up by the thyroid. If we immediately start giving our patients that were exposed or that have a potential for exposure potassium iodide, that actually take the place of the radioactive iodide that would have been taken up by the thyroid. So therefore, in essence, you're satiating the hunger of the thyroid for iodine for a non-radioactive form until you could actually get them away and get them away from the exposure of the dangerous radiation. Correct?
Yeah, that's awesome. Yeah, exactly. I think there's also like a drug. I forget what it's called. I don't remember. But yeah, that's my understanding. Yeah, because it's the same idea, right? Like you have a channel and there are two iodide goes through that channel. So normal iodide will go through it, radioactive iodide will go through it. So you just want to make sure that there's as much iodide moving through that channel as possible so that you can minimize the amount of radioactive iodide that makes it through. It's the same principle in a slightly different form for how we used to treat like methanol toxicity with ethanol. Same idea. In that case, it's an enzyme. You're trying to saturate the alcohol and the acetaldehyde dehydrogenase enzymes with the normal alcohol and not the methanol. Because when you metabolize methanol, that's the problem. It's the metabolite that's the problem. It makes formic acid ultimately. But same idea. Yeah. Exactly. So what I didn't know is that iodine was actually the form of the radiation. I didn't know that. That's cool. That's cool. All right. So what kind of nuclear medicine scan is thyroid scintigraphy? Well, I already said it in the name, right? So the general idea, again, is that you're instructed not to have iodine-containing foods or medications, because the idea is that if you give the regular iodine, right, then the radioactive iodine can't make it in. And so in the case of when you're exposed to radioactive iodine, right, in like nuclear reactor meltdown, then you want to give regular iodine. I wonder how much iodine is in like table salt. I wonder if that would be enough. Probably have like way too much salt to do it, but that's an interesting thought. If that's the only thing you had, just chug a bunch of salt after you buy a nuclear reactor. I don't know. All right. So let's talk about myocardial perfusion scans, because that was how we started this entire discussion. So Alex, can you tell us what's the basis of a myocardial perfusion scan in nuclear medicine?
I'm guessing it's just looking at the supply and demand and the blood flow over time to a specific part of the...
Yeah, essentially. Yeah. So, man, it's a good way of thinking about it. So, yeah, you give a radioactive substance, right? Remember, it's the cestim, oftentimes cestim maybe. So the 6 MIBs that coordinate around the technetium is the nucleus that will decay. It'll go to the heart because for whatever reason, the 6 MIBs like the heart. And so if there's an area that gets less blood, then it'll be less bright on the heart cross section. So the idea then is that we've got this heart, and if we were to section it, let's say that we were to cut it just like this, then we would see a scan like a CT, right? The tomography, because this is a SPECT scan. Remember the CT, the SPECT. So we're taking a slice. So if we were to slice the heart like this, slice one of the ventricles like this is the image that we might see. And so this is like a representation of it. And so there are different coronary artery territories that will supply different parts. So as you'll see here, right, the LED supplies this part, and the RCA is this part, and the circ is this part, right? So there's different ways of slicing it. You can either slice it the long way or you can slice it the short way. Great. So this is what a typical myocardial perfusion scan would look like. Again, the idea is that we're slicing the heart at varying depths. And so just like a CT where we're slicing the body and we're just looking at all the different slices, that's exactly what we're doing with the SPECT scan. So this is the short way and this is the long way, but that's the general idea. Questions? Because this, I don't know. I didn't really understand this when I was a medical student. No one ever explained this to me. All right, so what is a stress test? Let's talk about that. So Andy, using the pathophysiology, please explain the presentation of stable angina. So we'll hold the stress test talk for now, but just tell me what like the present.
So it's the presentation. So they're gonna have chest pain upon exertion, and the reason why is because there's not a lot of blood that can get to the certain part of the heart to actually meet the demand when you're like increasing, like exerting yourself because of the atherosclerosis.
Yeah, exactly. That was great. Yeah. So there's some sort of fixed coronary artery stenosis, right? So under normal circumstances, you would have enough supply to meet the demands of the heart. However, under physiologic stress, right? If I get really emotionally upset, if I'm exercising, whatever, right? Running on a treadmill, then my demand will increase. And my demand may increase to above what my coronary arteries. So ischemia, again, is just a mismatch of demand and supply, right? So there's more demand than supply. And so in this case, it's because my demand has increased. So it's only then during that demand increase, i.e. during exertion or during emotional upset, that I would have pain. But I shouldn't have pain at rest. So we've discussed this before, but what we didn't talk about, right, is Boogie. Can you tell us, if we were to look for signs of ischemia during rest for stable angina, and why?
Are we discussing an EKG or a nuclear scan, doctor?
Any of them. So if it's stable angina and we're at rest, would we necessarily see the ischemia?
I wouldn't say not necessarily, but if they are ischemic and if they are ischemic, we should have some compensatory mechanisms occurring already, such as maybe some tachycardia.
Maybe. Why would you see tachycardia though in ischemia? Really? Why?
If the heart muscle itself was already starting to become compromised and there was hypooxygenation, then I would assume that the heart would try to make up for it by either increasing its contractility or increasing the heart rate to try to supplement what it's not getting.
Normally, I would agree with you wholeheartedly. Like pretty much any other organ of the body, I think that's probably true. The exception is the heart. Because remember, right, when you're talking about compensatory mechanisms, what are you doing when you're increasing contractility or increasing to the demand?
You're actually using more oxygen.
And when does the heart fill? Is it during systole or diastole?
During diastole.
Yeah. And the reason I know this is because this actually comes up a lot in anesthesia. Like you want to slow down the heart, if anything, in ischemia. Because you'll decrease the demand, but you'll also increase the supply as long as you maintain the blood pressure.
Yes, maybe I misunderstood the question. Sorry.
It was a bad question, honestly. What I'm getting at is the idea is that if I'm at rest, if in stable angina, right, the pathophysiology is that at rest, I get enough supply to meet the demand.
Yes.
So I will not necessarily see ischemia.
I understand. But however, in a nuclear scan, if there is ischemia, that particular part of the myocardium may be cold, correct?
Maybe. But if it's just stable at angina, you might not see it. Building towards, it'll make more sense when I ask the next question. So when your demand is met by the coronary supply, you shouldn't see ischemia. So let me ask you, Boogie, though. So what is the basis of a stress test? So in other words, what I'm building towards is like, why are we doing the stress part of it? Why would we make my uncle run on a treadmill or get dobutamine injection, right? Like why? What's the purpose?
My understanding is that we're trying to recreate a potential cardiac event, either one that they had or one that they might have, say, next week.
Yeah, sure. What are we doing? What do we make them do? And what is that reproducing?
What we're doing is we're increasing the myocardial demand, the oxygen demand during that particular phase. And so therefore that could indicate to us that they would not be able to meet that demand. So therefore there must be some sort of pathology of disease that's underlying that we would not have noticed if we did not do the stress test.
Exactly. So in other words, right, so just like you only get pain, you may only have pain if you increase the demand of the heart so that you see the ischemia only when there's an increase in demand. The same thing is true for coronary stenosis. So at rest, I may have enough blood supply to meet the myocardial demand. However, if my question is there a coronary artery disease in the first, right, it might only show up during that stress event. And so stress tests are done specifically to increase that myocardial demand. So the idea is you're trying to pick up on stable angina, right? The sort of fixed coronary stenosis that you would see that would lead to stable angina. Cool. So Shama, so what's the difference between an exercise and a chemical stress test?
So exercise would be basically if the patient is able to are they able to move? So we want to have them go on a treadmill and basically increase the myocardial demand through exercising. But chemical, we would probably give like dobutamine. So dopamine to increase myocardial demand through that way. And that would be usually for patients who are like elder, who have like arthritis and can't move, or any contraindications to exercising.
Yeah, exactly. Perfect. Yeah. Honestly, I don't even think as a resident, like early residency, I don't think I ever knew that. So that's really good. Yeah. Exercise, if you can move, yeah, then you'll do an exercise stress test. If you can't, so if, let's say that, yeah, you're bedbound. Let's say you have really bad heart disease, like you have bad heart failure. You can't. You get short of breath every time you move, or let's say that you have a broken hip or you have bad knees or something like that. They can use something like dobutamine, so beta-1 agonist, that will increase the myocardial demand. And so beta-1 would increase your contractility and your heart rate, like we were talking about before. So we talked, so why would you do one versus the other? So exercise, it's usually the default. Generally, you try to get them to exercise if you can, and if you can't, right? If they can't exercise because it hurts, or got bad knees or hips, or they broke their femur or something, then you would do chemical. It's like your backup plan. Cool. So we basically talked about this, right? How is it performed? No, let's talk about it. Danielle, so how is a stress myocardial perfusion SPECT performed? What do you do?
So I think we already talked about it. So we give them an IV of the radio labeled like isotopes, and then as they're exercising, this would show up this would mark the ischemic areas during the exercise test.
Yeah. Basically, you do two portions, right? So there's one at rest and one of them's done. I think they exercise for 5 minutes or however long it takes for them to get to their target heart rate. And then you compare the two images. That's it. You're looking for signs of reversible ischemia. So what does this scan show? Deb, do you know? What do you see?
I guess there's decreased perfusion. So
in which image? The top one or yeah, exactly. Yeah, right here. Good. Yeah. So like right here, basically. You see how it's not quite as bright as here? Nice. Well done. So Hadra, why do people normally get a stress test? Like in this patient, why did our patient get one? It's a 55-year-old guy, type 2 diabetes, normocytic anemia, chronic kidney disease with exertional dyspnea. Why did they do it?
The stress tests are basically done to see how significant is the coronary artery disease.
Yeah, or basically to see, does it explain like this? So you're assessing for coronary artery disease because someone like this, like what if he'd been a smoker, let's say? There are other reasons why you can, like exertional dyspnea is a pretty nonspecific sign, right? It could be heart, it could be lungs, it could be because of his anemia. Anemia can give you exertional dyspnea. So it's a way that you can, so chest pain can happen for a variety of reasons. It's a way for you to see, is this coronary artery disease? And also to assess maybe how bad it is. But really it's to tell you it's coronary artery disease. So he had risk factors. So it makes sense that they would order a stress test in this case because they're trying to assess for the cause of that exertional dyspnea. Cool. All right. So now we are back at our vignette. So again, I will read it and the speed that I would read it. So a 55-year-old man with type 2 diabetes, normocytic anemia, and chronic kidney disease comes to see his primary care physician for evaluation of exertional dyspnea. Blood pressure is 141/93 and pulse is 82. BMI is 35. Single photon emission CT images at rest and after 5 minutes of exercise on a treadmill using separate intravenous injections of technetium 99 labeled perfusion agent are shown to the side. What is the pathophysiologic chronology? So I'm going to let you guys write in the doc to tell me what the pathophysiologic chronology is, and then we'll talk about it briefly. All right, thanks, friends. All right, so I'm going to give a little bit of feedback. So I'm just looking at Yuki's looks good. So born healthy, similarly poor lifestyle choices, gets diabetes, then gets kidney failure from that, obesity, and maybe some hypertension, anemia from the reduced EPO from CKD. I agree. Although I don't think that leads to coronary. This is maybe a bit of a splitting hairs, but I wouldn't say that leads to it. I might just say plus. Yeah, a side tangent. Yeah, or like in addition to leads to that. Atherosclerosis narrows coronary lumen, reduced flow, symptoms of exertional dyspnea. That leads to SPECT at rest shows fully perfused heart, but then on exertion, it shows decreased perfusion, and that leads to the chest pain. Yeah, great. Exactly. Let's look at boogies. So man, Boogie went into a lot of detail. So chronic diabetes type 2, hyperglycemia leads to sorbitol increase. That's true. I never knew that about decreased fatty acids. It's interesting. I didn't know that. Deposition of atherosclerotic plaques. Atherosclerosis leads to stenosis. Good. Turbulent flow, maybe. I don't know that you have to necessarily invoke on flow though. The whole point is that like Yuki was writing, right? Like at times of increase in demand, you will see the ischemia on the SPECT scan, but at times of normal demand, right? When you're at rest, you shouldn't see it. Again, the anemia leading to RAS increased. I don't know if that's true. I don't think that's true. Is that RAS? Maybe. So I guess in the sense that sympathetic tone is connected to RAS, and you could have an increase in sympathetic tone from anemia. I suppose that might be true. But yeah, higher demand in the system, O2 consumption. So the exertional dyspnea, again, all I would think about for the exertional dyspnea is that it's cardiac, right? It's because of the coronary artery disease. You're getting cardiac ischemia. Great. So I will tell you what I would have said, just as a general idea, right? So like we said before, coronary artery disease, stable angina leads to pain and ischemic physiologic stress, and that leads to reversible ischemia on the nuclear medicine scan. My more detailed explanation would be that he's born healthy. He had some cardiovascular risk factors, right? So specifically in this case, diabetes and obesity. He developed stable plaques or a stable plaque in his coronary artery, and that leads to occlusion of greater than 70% of the lumen. And so that leads to the symptoms of stable angina, right? So ischemia during physiologic exertion. So during the stress portion of the SPECT, of the nuclear medicine scan, he develops ischemia as the demand increases over the supply. So there's other ways, like I didn't explain in this case, why the diabetes led to the chronic kidney disease and why the chronic kidney disease would lead to a decrease in EPO and why the decrease in EPO would lead to anormocytic anemia. I probably should have done that if I had been complete, but this would be my more detailed explanation. Awesome. Any questions? I know this was a lot. This was a big one.
I have a question.
Yeah, please.
So I just had a question about the hot and cold thyroid nodules, and I was just wondering why cold nodules would be more commonly malignant and hot ones would be more benign and more functional.
Yeah, great question. Yeah, so it just comes from the observation that cancer typically is not hyperactive. Cancer, for whatever reason, doesn't produce thyroid hormone. And you can like justify, wave your hands and say, oh yeah, well, it's cancer, so it's as different from the cell as possible. You think of a pituitary adenoma, right? So adenoma meaning it's a benign neoplasm, not a malignant neoplasm. Those are the ones that are likely to be like a prolactinoma, right? Ones that secrete something else. If it's malignant, again, it's like the cell has now changed in pretty significant ways. And so the idea is that cancer is unlikely to produce thyroid hormone. So you can wave your hands like I did and explain that cancer is pretty different, but that is generally true. So that's why it is reassuring when you see a hot nod. That makes sense.
I was just assuming it was like because the cancer cells would be outgrowing the blood supply, so maybe the blood wasn't getting to the center.
Oh, that might be true as well in part. But remember, it's like only a portion of the cells are going to necrose. If all the cells necrose, then you wouldn't have to worry about cancer, of course. Okay. But it's a good thought. But I think it's the idea that cancer cells themselves just happen to not produce thyroid hormone, which generally is true. Most cancer cells, that's not always true. But generally speaking, though, like cancer cells are the more malignant things are, the less likely it is to produce other stuff. The obvious exceptions being the ones with the paraneoplastic syndrome, like small cell or things like that. Awesome. Thank you very much, guys. This was fantastic. I'm really glad that we were able to discuss this because, again, this is something that I didn't understand at your stage.
Do you narrow down to 2 answer choices and always pick wrong? Or worse, realize your first answer was actually right? That's just one of 5 test-taking mistakes that cost students 20 to 30 easy points on the USMLEs. In the next video, you'll learn the USMLE test-taking tips that help students stop getting stuck between answers and start scoring 260+.